Performance Measures for Upper Gastrointestinal Endoscopy, a European Society of Gastrointestinal Endoscopy, ESGE Quality Improvement Initiative. Introduction. The European Society of Gastrointestinal Endoscopy, ESGE, and United European Gastroenterology, UEG, have identified quality of endoscopy as a major priority and described their rationale for this in a first manuscript that also addressed the methodology of the quality initiative process. The identification of upper gastrointestinal (UGI) performance measures presents a considerable challenge in contrast to the situation with colonoscopy, for instance, where several performance measures, inspection time, adenoma detection rate, and interval cancers, among others, have been identified over the last decade. Following the Quality in UGI Endoscopy meeting held in Lisbon in 2013, it was clear that there was a need to identify performance measures for the UGI tract, and that quality standards could be identified, although there was a paucity of evidence. This lack of evidence, however, helps to identify research priorities for the development of clinical trials that will further validate and substantiate the implementation of performance measures. The aim, therefore, of the UGI working group was twofold. 1, to identify performance measures for UGI endoscopy, and 2, to identify the evidence or absence of evidence that would develop the research priorities in this field. Bisschops et al. Used an innovative methodology to facilitate the quality initiative process, which combined a thorough search and standardized evaluation of the available evidence for each clinical question, followed by a Delphi process using an online platform. This online platform permitted iterative rounds of modification and comment by all members of the UGI working group until agreement was reached on the performance measure. In this article, the authors now report these newly identified performance measures. General conclusions, research priorities, and future prospects. This paper describes the first performance measures generated by evidence-based consensus that can be used for UGI endoscopy. Bisschops et al. Used a systematic and scientifically sound methodology to substantiate the proposed measures with available evidence where possible. As this is a largely unexplored field, most of the generated evidence is, as expected, graded as low quality. This in itself generates an important research priority, which is merely to measure the proposed performance measures and to evaluate whether they do, in fact, influence health outcome. The working group identified several additional research priorities. These are listed in the article and will be addressed in an additional manuscript from the ESGE Research Committee. The first step now is to implement these new performance measures into endoscopy practice in Europe. This is the only way forward that can evaluate the actual value of the performance measures and allow their adaptation in future. The working group members emphasized that all performance measures were perceived as important, but in order to facilitate their implementation, the authors made a distinction between key performance measures and minor performance measures. Although this distinction is somewhat arbitrary, attention was paid especially to patient safety, patient service, increasing diagnostic yield, and the feasibility of implementation. Indeed, some of the performance measures may be more difficult than others to implement or, because of geographical differences in disease prevalence, may be less relevant in certain centers. The implementation of performance measures is important to identify services and individual endoscopists with lower levels of performance. The authors encourage individual endoscopists, as well as heads of endoscopy units, to start the implementation of these performance measures without delay. At a unit level, this may well mean investing in hardware to accommodate a more efficient auditing process. Through individual feedback, measures can be taken to improve quality to rise above the proposed minimum thresholds. This should not be regarded as a Big Brother strategy with the goal of penalizing specific endoscopists, but rather as a tool to improve the quality of endoscopy in general, improve patient outcomes, and provide training and assistance where needed. A second barrier may be the financial repercussions of implementing a quality control system. Bisschops et al. Want to encourage hospital management to support the implementation of these performance measures in their endoscopy services. The authors think that in an era where general hospital accreditation has become more and more important, hospital administrations will be more inclined to support such actions. Moreover, we owe it to our patients to overcome individual or financial barriers to ensure that endoscopy services are of the highest quality and to set research priorities to gather data that will inform the next generation of performance measures.